Good morning, good afternoon, and good evening to all the trainees who have joining in the YouTube channel for our urology exam preparation series. We are doing episode 67. In this mock viva session, we will discuss the scenarios in male LUTS and BPE table. We have trainees here. Thank you for joining.
Thank you, Mr. Tanshi.
Good. Your time starts now. You have a 82-year-old gentleman presenting with history of frequency of urination both day and night time. How are you going to evaluate him?
So I'll review this gentleman in my dedicated LUTS clinic, ideally with the results of his urine dip, his uroflowmetry, post-void residue, 3-day bladder diary, and I'll take further history with regards to his symptoms, including any voiding and storage LUTS, apart from what has been told to me, his any hematuria, pain abdomen, any constipation, neurological illnesses, any known any significant past medical history, any prior urological procedures, any surgeries, any episodes of incontinence that he has had, any history of smoking, ethnicity. Yes, that's all in history. Then I'll proceed to examination with his consent in the presence of a chaperone, where I'll look at his general condition. I'll be assessing his ASN performance status. I'll look for any signs of renal failure, including pedal edema. On examination, I'll be looking for a palpable, on examination of the abdomen, I'll be looking for a palpable bladder, any scars, any flank tenderness, any suprapubic tenderness. I'll examine his genitalia next, and then I'll proceed to do a distal rectal examination where I'm looking for the prostate size, anal tone, and any nodularities in the prostate. Depending upon the findings from my initial investigations and history and examination, I'll proceed further.
Okay. In the history, he seems to have significant Parkinson's disease. In fact, is having the signs of shaking in front of your eyes. Examination wise, he is quite tall and thin built. Abdomen examination normal. External genitalia normal. DRE showed 60 cc smooth feeling prostate, and his urine dipstick is normal.
So, in view of these findings, I would have gone through his bladder diary. I would assess how bad his symptoms are, if he has any incontinence, if he has to get up, how many times he has to get up in the night. Is this primarily nocturia, or is this daytime frequency? With Parkinson disease, I'm aware that this can present with bladder outlet obstruction and detrusor activity. So I'll keep that in mind as well. And I'll get his uroflowmetry and post-void residue and then decide upon the basis of these findings.
Okay, his bladder diary shows fluid intake of approximately 800 to 900 ml every day. He drinks a couple of cups of coffee, one in the morning, one in the evening. He has frequency throughout the day and night. It's almost like every 2 hours he's voiding 40 to 50 ml. Nighttime he's getting up at least 3 to 4 times. His nocturnal polyuria index is around 25%. His uroflowmetry shows water volume only 60 ml and a peak flow of 8 ml per second and residual urine of 0 ml.
Because of these findings, first of all, I should have said this earlier, I would get his IPSS score as well. Now, because of the findings that I have till now, it does look like he has a small functional bladder capacity, and his significant concern is nocturnal polyuria. So I'll ask him to modulate his fluid intake in such a way that he should avoid taking any fluid for around 2 to 3 hours before going to sleep. I'll advise him that he should, when he's going to bed, he should empty his bladder completely. Now, here I will, once I've done these conservative measures, and his symptoms sound quite significant, so on the IPSS, it'll probably be in either the moderate or severe score. So I'm quite keen to start him on an anticoagulated because of these symptoms. At his age, I'll be careful about the possibility of dementia with them, as suggested by the Gray et al. Paper. And I will prefer to start him on trospium, which is a quaternary amino acid, 60 milligrams OD. It doesn't cross the blood-brain barrier. Apart from this, now, because he has a 60 cc prostate, I'm also quite keen to start him on finasteride and an alpha blocker. I will discuss starting him on all these three medicines. I will explain to him the possible side effects, especially with tamsulosin, that he may have postural hypotension, and he has to be careful when he's getting up to pass urine in the night. Preferably, if he has somebody with him, then that will be better. Otherwise, I'll warn him that if he feels dizzy when he gets up, then he should sit down for some time, allow his body to get used to this. So this is my plan. I would start him on these three medicines, and then I will follow him up in 6 weeks.
What do you mean by nocturia, nocturnal polyuria?
So nocturnal polyuria is defined as when a patient's urine output is more in the nighttime than in the daytime. So, for instance, for somebody who's more than 65, nocturnal polyuria will be more than 33% of the total urine output. However, for somebody who's less than 65, it would be 20%. However, for this patient, if he has to get up twice every 2 hours, then that means that he's not going to get a good sound sleep. So, although he doesn't qualify by definition of nocturia, that is still an important concern that I have in mind for his quality of life.
Okay, how far the Parkinsonism could be reason for his symptoms?
It is quite possible that Parkinson could be a reason for his symptoms. It is associated with detrusor overactivity, and he has significant storage LUTS. However, it is also possible that there is some element of bladder outlet obstruction here. It is not possible for me to comment on this uroflowmetry. So once I've started him on anticholinergics, hopefully his bladder capacity will improve slightly, and then I can review him in 6 weeks with a fresh uroflowmetry. There is some evidence with regards to this. There's a paper by Abrams et al. Who have suggested that the combination of it's called the Symphony trial, which suggested that the combination of anticholinergic and alpha blocker is better than just giving alpha blockers in patients with storage LUTS as well.
So why are you selecting trospium? What happens with other anticholinergics?
So other anticholinergics can cross the blood-brain barrier. Trospium being a quaternary compound, it doesn't cross the blood-brain barrier, and hence there is a possibility of protecting him from dementia. The other option would be to give him beta-3 agonist. For beta-3 agonist, for instance, something like mirabegron, as that is also known to increase his bladder capacity. But I would also consider his blood pressure before deciding on this. If he's hypertensive, then I would err on the side of caution and hold off on the mirabegron for some time. I would like to correct the name of the trial. It's the Adams trial, not Symphony trial. Sorry.
Okay, so you are prescribing this and explaining the complications and sending him home. When are you going to follow him up?
With anticholinergics, we should follow him up in 6 weeks to see response. I would like to use this opportunity to request him to fill another bladder diary, as it will provide me with an objective response, IPSS score, and a uroflowmetry and post-void residue, as we have not had a valid uroflowmetry till now.
Okay, again, is IPS score not much changed? Previously, it was like 28, now it's 27. Subjectively, patient feels a little bit more confused, and he is not very happy with the medications. He feel that he is more sleepy, and he's getting the giddiness episodes. Overall, he is not happy with any of these tablets. His uroflowmetry, not much change. Again, the water volume is only around like 110 ml with maximum flow rate of 7.5 ml per second, but is emptying the bladder completely.
So he's not happy with the medication. It's possibly the side effect is from tamsulosin. So I would stop tamsulosin, and because his capacity is not improving with this, and his post-void residue is 0, so I will add mirabegron to his medicines at 50 milligrams OD. At this point, I would like to take this opportunity to discuss further treatment. It is possible that we may have to consider Botox for him. But then, because of his age and Parkinson, I would significantly discuss the pros and cons, because there is a strong possibility that he may require CISC. However, Botox, and also I will tell him that this requires treatment again and again in every 6 months. But with Botox, the advantage is that it can be done under local anesthesia as well. So considering his Parkinson and age, that is a good option for his storage LUTS if he's not doing very well with the medication. But for the first trial, I would like to change stop Tamsulos and start him on mirabegron, continue the finasteride and trospium.
Okay. And do you think any of these Parkinson tablets need to be looked into?
Yes, I would like to see the compliance with the Parkinson medicine and do this in concert with my neurologist colleagues.
Good. So your time stops now. You did well. This is not just a straightforward, what can I say, like a middle age storage LUTS problem.
Yes,
I've really projected it into a very elderly man with predominantly storage symptoms. So the expectation is, are you able to correlate the possibility of the Parkinson's or any neurological problems with patients' LUTS? That's the main aim of the scenario.
Yeah.
Your approach is correct. I'm happy with the basic things. When the examiner is not giving IPSS score, don't assume, ask for it. I didn't need IPSS first, but you assumed it could be in the region of 20s, but you can ask for it. Nothing wrong in it. And nocturia polyuria index are correct, but when I say 25%, you should be quite clear whether it's significant or not for this age, because for his age, if you're taking 20% as the significant, it's significant.
This is 33%.
33% is significant, but I told nocturia polyuria index is 25%. But in one statement, you said he has significant nocturnal polyuria.
Okay, got it.
So just be clear in the percentage. I'm happy with you starting trospium and explanation why trospium is given, blood-brain barrier, etc. There is nothing wrong in keeping mirabegron also as one of the first-line treatment. But it's nothing wrong in starting trospium and keeping mirabegron for the second visit. Alpha blockers finasteride equally acceptable. He takes couple of cups of coffee, one in the morning, one in the evening. So you can touch upon switching to decaffeinated drinks, improving the hydration, and avoiding constipation, and C is mobility. I'm happy with your Adams trial. You came back quite comfortably. And the other things which are very specific for this scenario is you should involve carers. Patient is 80 to 85-year-old, so make sure you involve carers, next of kin in decision making. And there are some scoring systems in geriatric available. There is a Frailty scoring system, I think we shared in the WhatsApp few weeks before. So the main aim is to see whether you're looking at the patient as a whole, a frail elderly man. And at one point, you can even bring in the option of long-term catheterization. Nothing wrong in it. Because you have gone to the level of Botox. So there is nothing wrong in bringing the other options. Even for a fit 60-year-old going for TURP, when you're getting a consent, you should discuss the other options of clean intermittent catheterization, long-term urethral catheter, suprapubic catheter, TURP. Of course, as a surgeon, you will lean towards the TURP and consent and take the patient for TURP. That is acceptable. But you should present long-term catheterization as one of the option, at least after the first visit, maybe in the second visit itself. Who knows? That may make a miracle, and the patient may say, "Thanks a lot, doctor. This catheter changed my life," and he don't have to take all the 3 extra tablets when he has already a big pack of like a peel away pack, taking tablets every day. Okay.
Yeah.
Good. Well done. We have second trainee online. Okay.
Yeah, I'm ready. Thank you.
Good. Your time starts now. You have a patient, 65-year-old, presented with history of difficulty in passing urine. You have seen him earlier, evaluated him. His IPSS score was 29 out of 35 with QOL 6 out of 6. He is quite symptomatic with predominant voiding symptoms. His previous examination showed prostate measuring 90 cc, benign. His baseline bloods were normal. His bladder diary was normal. No evidence of any incontinence or increased frequency. You have started him initially on alpha blocker with combination of 5 alpha reductase inhibitors. When you reviewed him in 3 months' time, he has no major improvement. He was quite troubled by the side effects, and he wants to consider something more. How the side effects of tamsulosin and finasteride will present?
So the side effect of tamsulosin are dizziness, asthenia, retrograde ejaculation, and postural hypotension. Side effects of finasteride are mainly impotence, loss of libido, feeling of tiredness, and gynecomastia, that is in less than 2%.
Okay, so because of the side effects, he wants to consider something different. What is your option?
So, because he has tried it for 3 months, first of all, I'll confirm that he is compliant with the tablets. If symptoms hasn't improved with these tablets, then I have to consider that as a failure of medical management. So with his prostate size of 90 gram, I will ask him how important is preservation of sexual function for him. I'll give him the options like Eurolift, which is a minimally invasive and the standard treatment. The minimally invasive, I'll give him the option of Eurolift, which NICE has approved for up to 100 grams, provided that there is no median lobe. I'll give him the other options of standard monopolar or bipolar TURP and holmium laser enucleation of the prostate. I'm aware that there are other options like green light laser and also prostate artery embolization. And I'll tell him about the newer treatment options like aquablation and RESUM, which are not widely available, but however, if he is interested, I can refer him to an appropriate center.
Okay, he is interested in the newer things, but he's not happy with Eurolift because you said it has no long term study or follow up. He is taking anticoagulants for his atrial fibrillation. He is on a combination of aspirin 75 milligram and one of the newer drugs like rivaroxaban. So, will that make any difference in your choice of treatment?
It will. I will tell him that for his size of prostate of 90 gram, and one of the major things I had to ask him is how concerned is he with the sexual side effects of the treatment options. If he can accept the sexual side effect of retrograde ejaculation, then for him, my best, I can tell him that one of the best options is to go ahead with a laser enucleation of the prostate, considering the size of the prostate, the relief that it has shown in regarding the urinary symptoms in long-term studies, and also regarding his anticoagulants. It is much more safer to use laser procedures when a patient is on anticoagulants.
Why laser is safer for anticoagulated patients?
For example, holmium laser enucleation of the prostate. The holmium fiber, its activity comes in the hemoglobin range. There is a concept like the peak coefficient efficient is more of the term for that is a chromophore. The chromophore for holmium laser is the hemoglobin. So that's why holmium is better in cases where there is patients on anticoagulants. So it will act on the hemoglobin more and then can produce the coagulation.
What other laser options available for him?
Other one is the KTP laser, which is the green light laser. The latest one is the 180 watt laser, KTP laser, and that's also good, and has got well established role according to the Goliath study. And so these are the two main laser options we have.
Could you explain Goliath study?
So in the Goliath study, it is a non-inferiority study of green light laser with TURP. It proved that green light laser is non-inferior to TURP, and the outcome measures are equivalent to TURP. But the caveat of the Goliath study is that it considered that prostate size up to 80 gram only. So that's why EAU guidelines states that the green light laser can be used for prostate sizes up to 80 grams.
So how this green light laser works?
Green light laser works in the visible spectrum. It has got the frequency at 532 nanometer. It has got a laser resonator in which the KTP, YAG, both are present as a laser medium, and when the light source in that chamber is excited, it can produce laser, photons with the process of initially stimulated emission, and then with the help of two oppositely faced mirrors, the photons are augmented, and one of the mirrors has got a aperture through which the photons will come out, and that is fed through a optical fiber which is covered with glass.
Okay, can you explain the procedure for green light laser vaporization?
So previously, the machines used were 80 watt and 120 watt. However, recently there is new availability of machines which has got 180 watt. So now it has got more efficiency, so that the time of resection is much less compared. And so the green light laser is a side firing laser, and it acts mainly by the vaporization. So with all necessary precautions, once the cystoscope is in and confirming the configuration of the prostate, the laser is fired, and then it starts with the median lobe. And because it's a side firing laser, all the it's more like a vaporization or ablation of the tissues, prostatic tissue. One thing we have to make sure is that the ureteric orifices has to be well delineated, because it's a side firing laser, unlike a end firing laser. And usually after the finishing of the procedure, it's more like a rough cavity to start with. However, later, because of the necrosis of the cavity, a smooth cavity will form.
How the newer 180 watt laser is advantageous compared to the previous versions?
Because of the increased power, and also the fibers are much more efficient in the delivery of the laser. So one thing is that one is the efficiency of the delivery of the laser, and also because of the increased power, less operative time.
Okay. When you're doing green light vaporization, if there is like a vascular bleeding, how are you going to tackle that?
That's one of the side effects of the KTP laser, because its chromophore is mainly water. Sometimes the hemostasis is not as good as like in a homeo laser. So if it is severe bleeding, then we have to change it to a bipolar resectoscope, and then achieve the hemostasis with a roller ball.
Is coagulation possible with green light laser?
It is possible. But mostly it has got good coagulation capacity as well, but it is difficult to achieve a good coagulation like in a homeo laser.
Okay, the procedure went well, you created a good cavity. What is your exit strategy?
Once the cavity, once the surgeon is happy with the cavity, and once the hemostasis is achieved in a zero flow, then we will remove the resectoscope under vision, and then insert a three-way catheter. First, we will try to insert it without the introducer, and if not, then an introducer is used. The cavity, the balloon is usually filled up with almost 40 mils, depending on the size of the prostatic cavity as well. And then irrigation is started. Usually the irrigation is run for almost 3 hours, and then slowly tapered, and see if it is clear. If it remains clear, then the patient is sent home. It's because all these laser procedures are done as day case. So patient is sent home with the three-way catheter, and brought back in 24 to 48 hours for the removal of the catheter.
Okay, his catheter removal goes fine. You are seeing him in the follow-up. Last question. He has significant burning sensation while passing urine, dysuria. So what is happening?
My concerns here will be whether there is an underlying infection, so I'll do urinalysis, or it could be an underlying overactivity of the bladder. And yeah, these two will be my main concerns.
Okay, good. Well done. Again, a very box standard, straightforward scenario. The purposefully, I literally tracked you into the green light laser because that is one energy source we haven't discussed much. We have discussed holmium enucleation, we have discussed resume and Eurolift quite in detail. So I hope it's okay with you. Because it's sometimes there are some specific questions, like for example, the newer high power green light has got an improved coagulation. There are some techniques like focusing and defocusing. So if there is a point bleeder, we can defocus it. That will help to coagulate. The coagulation ability was quite poor in the 120, which is the second version. It was okay in the first version, but in the second version, somehow they got the calibration wrongly, and good vaporization, but coagulation was very poor. But in the third version, 180 watts, it's quite fast, and coagulation also is up to a limit. It's not necessary for every time to do a three-way catheter. You can make a call based upon how good the hemostasis is. If the hemostasis is good, you can even place a two-way catheter, and there are some units where they remove the two-way catheter end of the day, and patient can go home without the catheter also. So keep that in mind so that you have two three options. If it is exit strategy, if it is clear good hemostasis, you can come out without catheter also. Good that you brought in Goliath study, and there is another Goliath second study was planned. I'm not sure that the results were not yet out. I don't know why. Goliath 2 study, they have included patients above 80 cc. They've included patients with previous retention, patients on anticoagulants, patients who has previous cardiac issues, and lot of those patients were included. Even though we say that green light is good for patients on anticoagulants, in the Goliath 1 study, they have excluded all the patients with anticoagulants. So it's a shame that we should prove that green light is suitable for anticoagulants or not. And dysuria could be directly due to green light itself. So green light laser as a phenomenon will cause a cavity, and that can cause dysuria. It can present in resume also. It's a part and parcel of the procedure itself. So you can check for infection. That's a good protocol, but you should be also say that there is a possibility the way by which the tissue remodel and improve from the green light ablation itself can cause dysuria for few months. Okay,
Okay.
good.
Okay.
Can we go for the next scenario?
Uh,
Yep. Any questions?
I have a couple of questions, Mr. Day.
Yep.
Number one, first question is that when we're getting in this patient on anticoagulation or antiplatelet, do we need to stop
Yes.
and bridging by collection or no?
We need to stop as per the protocol. Even though the holmium and green light are good in the patient with anticoagulants, we have to stop as per the protocol. For example, aspirin 75 milligram, I don't stop for any
Yeah.
procedure, whether it's stress biopsy or open nephrectomy
Yeah.
or PCNL. Aspirin 75 milligram, I don't stop, but rivaroxaban has to be stopped for 48 hours.
Do you need to bridge rivaroxaban by the collection or not?
That depends upon the individual patient. Say,
But
for
if she has
example,
aortic metallic valve,
yes, that's what. So some patients, like as you said, metallic valve, they need continuous coagulation. They can't have a anticoagulation free period. So you can bridge with heparin, and then you can stop the heparin the night before, and you can restart the heparin maybe 6 hours after the procedure. That will be useful also for spinal anesthesia in case the anesthetist are planning for it. But if the patient, like our patient for atrial fibrillation, if he is on rivaroxaban, that can be safely stopped for 48 hours.
yeah. The other question is that the EUG guideline says that if the patient is on anticoagulant, then the holmium is the best option rather than the PVP.
Yeah,
Because
lasers are
sorry.
best. And of the lasers, as Anish said, definitely holmium scores better than green light. But we have discussed holmium enucleation in the past, so that's why I want to discuss the green light for him.
That's good. So my third question, my understanding is that the whole the green light laser, I say that it should be only on the randomized control, not for routine. So what should we see in the exam?
If you see in that angle, resume, Eurolift, aquablation, green light, all these agents have to be done in a clinical trial settings. So
In a clinical trial.
yeah,
Yeah.
you should do an audit. Anybody who's doing that will keep an audit on what is happening. And for example, Eurolift, they conduct national collection, the company itself, so that we'll keep an eye on the outcome. Yes.
So this is the PAE, PAP, PVP, and then the regime, they should all goes under the green
Anything
fertilizer.
except
Okay.
monopolar, bipolar, TURP, and HOLEP, and open
Hold it.
prostatectomy. All
That's
other
fine.
agents we should do with
Yeah,
audit coverage.
that's good. Thank you very much. Thank you.
Okay, can we start the next scenario?
Yes, please.
Okay.
Just one. Sorry, Mr. D. Just one question: isn't the chromophore for holmium water and green light hemoglobin?
I'm not very sure when Anish used the
I'll
word.
have to check.
We need to check it, but we are very sure that one is for water, one is for hemoglobin. My understanding is holmium may be better for hemoglobin, but definitely holmium is a very good in coagulation. That is very
Yeah.
good compared to anything. For example, if you do anatomic enucleation of prostate with holmium, bipolar, or thulium, holmium definitely scores better in coagulation.
Got it, Mr. Dash. Yeah.
Okay. Okay, for the next scenario, your time starts now. You have a patient who presented to A&E with acute retention and they have kept a catheter. On evaluation, they found that he has 200 cc prostate with a large bladder stone measuring 4 centimeter, a single smooth large bladder stone. So, with the catheter, he presented to your clinic. How are you going to evaluate him?
Sorry, I would see him in the clinic and take focus history and examine him. Mainly, I would like to know whether he had any previous low urinary tract symptoms, whether he was, first I would confirm his age, know whether he had any previous low urinary tract symptoms, any recurrent urinary tract infection, previous history of low urinary tract surgeries, prostate surgeries, whether he has taken any tablets for his prostate, his past medical history, surgical history, and examine him in the presence of chaperone with his consent, his general condition, BMI status, abdominal examination, any palpable masses, genital examination, and I'll perform a DRE to see any abnormal nodules to be felt. And I would ask him how he's doing with catheter when he was inserted a catheter, and his ideas, concerns, and expectations.
Okay, he's doing okay with the catheter. They have given him a flip flow valve that is making him a little bit more comfortable rather than the leg bag. Examination wise, he's 70-year-old, no major medical comorbidities other than past history of cardiac stenting something around 8 years back, but he's not on any medications for it. And abdomen is soft, extended genitalia healthy with catheter in place. DRE showed, as I said, quite a huge prostate. You're not able to even get to the top of the prostate on examination.
I presume that he is keen on getting rid of catheter, so I will discuss him with the available options of treatment. The main concern here is the size of the prostate and also the presence of bladder stone. He has two options. One is to go for a removal of the bladder stone and treat the prostate with a laser prostatectomy, something like HOLEP, which is almost equivalent to an open prostatectomy. So I would give him this option. This could be done as a two-stage operation because of the size of the stone, and maybe sometimes, if it is possible, we might be able to do one stage. We'll discuss that. And the second option is an open prostatectomy with removal of the bladder stone as a one-stage procedure, but this is more morbid than the whole procedure. So I will discuss in both these options. The other option is, which is less favorable option, is to treat the stone and then see how he's doing with the low urinary tract symptoms, because latest guideline says that almost 27% of the patients after removal of the stones, they are doing well with medical management for the prostate. So in this line, I would counsel him.
Okay, his prostate is almost like a 220 cc. Do you think just by removing the stone alone, he will have a better quality of life in future?
No, I don't think so. But if he is not willing for a surgery, I would give him the option of clean self-intermittent catheterization, but I'd keep this option as the last option.
Okay. Now, if you are planning whole up surgery with stone clearance, How are you going to approach? What is your priority? How will you decide whether he will need a single stage or two stage?
Um, First thing in the surgery to clear the stone. So it's a 4 centimeter stone. So this could be cleared with a laser. And the deciding factor is the time taken to clear the stone and the how he is doing at the time of anesthesia and how confident the surgeon can continue the operation. So depending on this, the options would be either to clear the stone and then completely do a second stage procedure for the prostate, or else if the stone is cleared and if there's some time left, then enucleation can occur, and then after few days a morcellation can be done in a different day, or else the other option is to do a part of the prostate enucleation and then do the rest at the second stage. So all these could be done based on the day of surgery.
For example, if you treat the stone and enucleate the prostate completely and come on a later date for morcellation alone, what is the advantage? And if you plan that, how long you will wait before morcellation?
The advantage is one, you don't need a prolonged anesthesia on the first day. The second advantage, once it's enucleated, the prostate size will shrink. So when you do the morcellation, it's a bit safer compared to morcellate a large prostate. 2 to 3 days is enough. So we can do the procedure, the second procedure during the same admission.
Okay. Patient prefers a single procedure. What may be the choice?
An open prostatectomy with the removal of the stone, open cystal thelopexy.
Any other alternative methods available?
Mm, a single, if it is single surgery, that's what I think. I'm not exactly sure, which is not done in my practice. I don't know whether a KTP laser vaporization would be an option. I'm not exactly sure.
Okay, so patient opted for single surgery and you're planning for open procedure. How are you going to proceed?
I would explain him about the procedure, counsel him. This will include the aim of the procedure is to remove the prostate and also the bladder stone. I would tell him practically it involves incision in the lower part of the abdomen and removal of the prostate, and then we'll rejoin the urethra. We'll do a urethral anastomosis, and there will be a cut in the bladder as well to remove the stone. The complications include infection, bleeding, which is more compared to the other endoscopical methods, and he might need blood transfusion and the blood and neck strictures in long term. And I would give him a BOSS information leaflet on this.
So, what type of prostatectomy you are doing for him?
It would be a Million's retropubic prostatectomy.
Why can't transvesical? Anyway, you need to open the bladder to remove the stone.
Yes. Sorry, yeah, it's a transversical prostatectomy, yeah.
So, again, go through the steps of transvesical prostatectomy.
The low midline incision, and then bladder is opened transversely with the stitch in situ, and then the bladder stone will be removed, and the prostate will be enucleated through the transversical approach, and the hemostasis is maintained. Bladder is closed with the two-layer closure, watertight confirmed on table. The patient will have a suprapubic catheter and the urethral catheter. A drain is kept. The catheter will be removed in 10 days after streptocystogram to make sure the bladder is healed. Drain will be removed before the patient is discharged in 24 to 48 hours.
Okay, you have to keep the suprapubic catheter for all the patients?
I would keep it. First, I would make sure the bladder is healed and they remove the perurethral catheter, and if the patient is and the suprapubic catheter will be clamped, and if the patient is doing well after a few days, maybe if I remove the perurethral catheter in 10 days, in 2 weeks time, if the patient is voiding completely fine, I would take the suprapubic catheter off.
Okay, so how are you going to follow him up?
I would see him in the urology clinic in 3 months with a repeat flow rate and IPSS questionnaire to see how he's doing well in himself in terms of symptoms. I also would like to have a ultrasound scan for his upper tracts to make sure that he has no other stones in the upper tracts as well. And if he's okay in 3 months visit, I would discharge him to the GP, saying that to keep an eye on him and then to refer him back if there is any trouble.
Okay, he's fine in 3 months' time. He's voiding well and no major concerns. But almost like 1 year later, he presented with again slowness in passing urine and he needs to strain to empty. So, what will you do?
Again, I would see him in the clinic, take focus history. My main concern here is whether he has developed a stricture, blood and neck contracture. So I would do a flow rate in the clinic, make sure that he doesn't have any urinary infections. And based on my flow rate pattern, I would arrange for a flexible cystoscopy to diagnose any strictures or contractures and take it further from there.
His flow rate showed a obstructive pattern with peak flow of only 5 ml per second and he has residual urine of 120 ml. So we are doing flexi. What are you expecting?
I want to, I would expect the anterior urethra whether there's any stricture, but the most likely possibility is he might have a blood and neck contracture. And in the bladder, I would make sure that he has any further stones.
So what is the treatment for bladder neck contracture post prostatectomy?
It's the dilatation, bladder neck incision under general anesthesia.
Okay, we'll stop there. You did well. Again, I really want to discuss the open prostatectomy because other modalities we have discussed before. Preparation, everything is fine. Large stone, large prostate, open prostate is the best method if the patient wishes for a single surgery. You came back because transvesical is better because you're opening the bladder. There is no need for retropubic prostatectomy. You're happy with that?
Yeah. Okay. I have not. I only seen 1 million, so I went for that. Sorry. Yeah.
Yeah. The other thing is when you are doing the holmium enucleation, the mosrelation is the most important part with a lot of complications like a bladder injury, maybe even to ureteric orifice, etc. So if you've already spent 1 or 2 hours for the bladder stone and then enucleation, and then you will be very tired during the third most important mosrelation stage. So you can say that. That's why I want to do a staged holmium surgery in which I will treat the stone first and then evacuate all the stone fragments, do the enucleation, and then I will come on a fresh mind and body in 2 days time for mosrelation, so that the examiner should understand that you are giving importance to the mosrelation step. It is not just the third step of removing the specimen. It's the most important step in whole up. Okay.
Can you do a part of enucleation as well as I told?
Yeah. Part is also fine. You can just enucleate the median lobe and one of the lateral lobe and then come for the lateral lobe again. Nothing wrong in it. But make sure you are mentioning that mosrelation is one of the procedure which requires good concentration. We have good mosrelators now, but it depends upon the day, how long the stone takes to fragment. I was really waiting for you to bring robotic simple prostatectomy. But I don't want to prompt you also. So in these scenarios, please remember the role of robotic simple prostatectomy, and we can go retropubic if there is no stone like any other patient. But most of the robotic prostatectomy, simple prostatectomy, especially in US, even without stone, they are going transvesical. So it's almost mimicking the open surgery. We can remove the stone with like a specimen basket and transvesical prostatectomy. So don't forget that. I thought if you say that, I will ask few questions in that. So this is what happens in the exam. You may think that you have done perfect and the scenario is open prostatectomy, but if you're not bringing an option, sometimes the examiner will just stay quiet. So it's not a bad thing. You're not going to get low mark, but it's quite obvious. Any patient who needs open prostatectomy in 2021 also discuss the option of robotic simple prostatectomy. Okay.
Yeah. And if you do transvesical, do you still do the anastomosis, urethral anastomosis?
No. Transvesical is just enucleation. That's it. So the outside is still preserved, outside layer. So there is no discontinuation as such. Just how you do the holmium enucleation with the help of the laser tip fiber, you are using your finger, monopolar tip cautery, and other things to enucleate the median lobe. Still, some peripheral zone and capsule of the prostate is still preserved. So there is no place for vesico-urethral anastomosis.
Oh, right. Okay.
Okay,
Thank
good. Can we go for the last scenario?
So one question, please.
Yeah.
So just you mentioned the robotic simple prostatectomy, but how will you combine it with the stone?
Yeah, so robotic simple prostatectomy, you're just getting into the abdomen just like how you do a prostatectomy. You will be
Yeah.
opening the bladder, take the stone, put it into a specimen basket, and then keep it on the side. Transvesical, go and remove the prostatic lobes, and then again put it back into the specimen basket. And if the basket is slightly bigger, you need to make a bigger incision to remove the stone.
And is it possible when you do you have done the pneumoperitoneum?
Sorry, pneumoperitoneum?
Yeah. Do we need to do the pneumoperitoneum when we do
Yes, yes.
the?
Yes, yes, yes. It's just any other normal one. It's normal. As usual, you will create a pneumoperitoneum. You can stay in the peritoneal space if you want, but with the robotic equipments, pneumoperitoneum is always better because you need some space to work on.
So in that case, the carbon dioxide will not go through the bladder and into the urethra into the bag when we open the bladder.
No, no, not really like that. It won't leak that much because you are already operating in that area. It won't leak that much.
Oh,
There are
because
plenty of robotic simple prostatectomy transvesical, not even case reports. There are case series are presented.
I have never seen, so that's must be, yeah,
Yeah,
yeah.
just you can
Thank-
Google it and see some YouTube videos, or even there are some good articles from Cleveland Clinic. Mr. Mihir Desai, he has done a series. There are people in St. George King's Hospital in London. He's got the largest publication for UK, and even in Asian countries, they are doing robotic simple prostatectomy now.
Oh, thank you very much.
Good. Can we start the last scenario?
Yeah, I'm happy to start.
Good. You have a patient diagnosed to have carcinoma prostate. He is having Gleason 7 prostate cancer, 3 plus 4. He is otherwise quite fit. Unfortunately, on staging, they have found that he had at least 5 different areas of bone metastasis. His baseline PSA was 84, and his age is say 75, and he was started on bicalutamide plus LHRH injections. He improved well. His PSA dropped to 14, and you reviewed him in 3 months time with this drop in PSA. He said he is tolerating his injections well, and you thought of referring him to the oncologist even in the initial setting itself to see whether he'll be suitable for any upfront chemotherapy. In the meantime, he presented with urinary retention. What are going to do?
So I will see this man in my dedicated LUTS clinic, along with the bladder diary, IPSS score, flow rates, and PVR, and urine dip. And then take the history. In the history, I know that is the history of CA prostate on this blue biclutamide. And then I will ask is there any previous intervention, or he has a previous medication for his prostate or low unit tract surgeries, and then ask about uh, his other illness like diabetes or any other neurological problems, and then make a notes of medication, including anticoagulations, and then I will move on to his. I have included my flow rates PVR as well. So I now move on to examination. In the examination, I will see the general physical examination and focus on the abdominal, palpate the kidneys, bladder, and do the perineal examination, see the penis size, any phimosis, and then see the testes, and then do the with the chaperone and consent, do the DRE examination, make the see the tone of the anal sphincter, size of the prostate, and then I will do the neurological examination, and then I will move on to the investigation, which will include the baseline UNEs, FBC, and CRP, and then take it from there.
Okay, his blood investigations were fine. Examination wise, he is 80 kg man, moderately built, abdomen and genitally examination normal except for the presence of catheter. DRE showed something around like 40 cc prostate with a kind of firmness because we know that he had previous prostate cancer and on medications. What is your next step?
So what is his flow rates and PVR, please?
He's on a catheter. He presented with acute retention.
Sorry. So I thought he has no catheter in it. So it's my scenario acutely changed. So in that case, I will give him a trial of alpha blocker according to per L4 study, alfuzacin 10 milligram for 3 days and Boca at work in 1 week time, and we'll reassess him after that work.
Okay. Why you want to select alfuzuzin?
Alfuzacin, because this the Alfur study, they have that trial which showed that it has a better TWAC success result, 62% as compared to the placebo, which is 42%.
So what happens when you use tamsulosin?
Tamsulosin is the same one, but according to the study, it was not. It was done with alfuzacin, but the tamsulosin will be the same.
Okay. And compared to a patient who has no prostate cancer, is there any difference in this patient who is going for trial ward without catheter with alpha blockers?
Because he's already on the biclotamide, which shrink the prostate size. But if he's not, then when he needs a long-term management with the finasteride, alpha 1, 5 alpha reductase inhibitors.
Okay. Unfortunately, his trial void failed. And after how many days you will give trial void after starting alpha blockers?
After for 3 days.
Why 3 days?
Because it takes 48 hours to work, so just on safe side, 48 hours to 3 days.
Okay, you are doing the trial void in 3 days. As I said, unfortunately, the trial void failed. He didn't empty the bladder.
So again, then I will see him and then see how much his PVR and then how much was his quality of life IPPS score. Then I will offer him that he needs. I will assess him with the flexible cystoscopy to rule out any stricture and to see the prostate size. Maybe it's a large intravesical prostate, and then in that case, I will offer him the depending upon my cystoscopy finding, what is that?
Okay.
I will go take it from there.
His pestal urine when he failed at walk is around 120 cc, and he was kept on a catheter again. You are doing a flexible cystoscopy which showed a trilobar occlusive prostate. And so what are you going to do? Bladder normal.
Bladder normal. So in that case, I will discuss the option that with the ongoing treatment for his prostate cancer, it will shrink the prostate. And also, I will offer him if the discussion of CISC, a long-term catheter, or the bladder outneck obstruction surgeries, which will be in the form of Resium, Eurolift, because he's 75 Eurolift, and then the TURP or the Holmium.
Okay, he is not happy with the catheter. He heard about the various options, what you said. So, what is the best option? What are you going to give him? He says, Doctor, you please choose the best option. I don't want the catheter. I'm not happy with the tablets also.
So my options will be depending upon that whether he wants to keep his retrograde ejaculation or he compromise it. Then depending upon the available sources, my first option will be the Resium as per the NICE guideline, because and then the TURP and then the Holmium, but also depending upon the patient choice.
He is not bothered about erection or ejaculation. He wants good urinary stream free of catheter.
So again, I will discuss the option of Eurolift in that case as well, if he happy. So,
what is the evidence of Eurolift in a patient with known prostate cancer?
Sorry, I cannot recall at the moment.
Okay. Patient studied the leaflets you have given for Eurolift. He is not very satisfied having metal implants in the prostate with the prostate cancer also happening. So, what is your next choice?
So my next choice will be the TURP or the resin.
Okay. Patient opts for TURP. How are you going to prepare him?
So my preparation will be the pre-op, which will be the his I will his all patient his UNEs should be up to the correction of his sodium. Make sure that his hemoglobin is a normal range, sodium is a normal range, and because it's long-term catheter, then I will check his. MSU especially, and if he has a grown and bacteria, I will give him an antibiotic before the operation and during the operation as well. And then after that, I will consent him with the TURP both leaflet, giving the information regarding the intraoperative and early and late. Intraoperative is the bleeding infection and the TURP syndrome, and the early late will be the fail of TURP, and then late will be the erectile dysfunctions, urethral strictures, and or he may need a repeat TURP.
Okay, you are planning TURP. In which way his TURP will be different from any other TURP we do for BPE?
Because in this he need a channel TURP to relieve the obstructions, and I will not go into the full resection of the prostate because he's on the will be on the bicalutamide which will shrink the prostate.
Okay, why channel TURP for him?
To relieve the obstruction because with the anti-androgen therapy, the prostate will shrink in the long-term basis. In the long term.
What additional side effects he may have compared to any other patients going to TURP for benign enlargement?
The additional side effects that there's a chances of external sphincter injury, and his prostate will be the harder, and it will be a little bit difficult TURP as compared to a normal one.
Okay, you are doing TURP and the whole tissue came as a benign prostate. Is it possible?
Yes, because we're doing the transitional zone and the prostate cancer is in the peripheral zone. Yes, it is possible.
Good. We can stop here. You did well except for two main things. I think you missed the fact that I told you the patient presented with retention. And so anybody who's coming with retention, there is no real big role for bladder diarrhea, IPSS or flow
rate. Of course, and I'm sorry, I didn't note this point. Yes,
yeah.
Sorry that.
And you can still do bladder diarrhea IPSS. The only thing is you should tell the patient that just think what happened in your life before you had a retention. Yes. If the patient had retention only 3 days back, still you can get some baseline IPSS. Just be mindful in that. And there is no role for primary urolift or resume in a patient known prostate cancer. There is no evidence behind it. And having said that, there are some case series on patients having urolift years and years after prostate cancer diagnosis, after radiotherapy for prostate. That is different. Patient had a radiotherapy of prostate in the age of 70, presenting at 79 with difficulty in passing urine and having urolift. That is done. That is only more of a case reports, I will say. So be careful when you're selecting which energy source. I will say I will go for channel TURP or whole beam enucleation. Again, whole beam enucleation is overkill. You clearly said that bicalutamide and even the LHRH injections are going to shrink his prostate size, peripheral zone. So ideally, he should have a very good talk with the alpha blocker itself. So if he fails, a good channel TURP is the minimalist thing for him. He has increased episodes of urinary incontinence compared to others because when you are doing the channel TURP, there is a possibility of weakness in the sphincter which get attenuated because of the prostate cancer and because of the surgery also. And there is no real reason that you should give only alpha-Zusin for trial void just because of alpha study. You can extrapolate and use it for the other alpha blockers also. So you can say tamsulosin, but if somebody asks for evidence, you can quote alpha study and say that in alpha study alpha-Zusin is used. Don't take it as a reason to give alpha-Zusin. Okay, you can give tamsulosin, which is equally good. Yeah, my main aim is to bring out the channel TURP, which we haven't discussed in this platform before. So just to give importance, what is channel TURP, what is the principle behind it, why it is different from the normal TURP, what other additional side effects you will explain the patient. In a patient with known prostate cancer presenting, do not bring urolift, resume or hold up. Not much role in it. Okay.
All right. Okay. Yeah. Thank you.
Any questions before we stop?
Yes. The first case we discussed, the Parkinson. Is there a role for urodynamic at some point for the patient?
If you are doing Botox, definitely there is a urodynamics. But if you are trying to manage him more of symptomatically by lifestyle changes, we can wait. He is 85 and he is too frail actually. But even by urodynamics, how far he will really give a very meaningful urodynamic output, we don't know. But I will be having a very a low threshold not to go for Botox, so I will also not put him to aerodynamics so quickly. So lot of collaboration with the geriatric consultant, making sure that his non-urology medications for his Parkinson's are not jeopardizing your approach for the bladder, and lifestyle changes, and as you said, trospium or mirabegron are the best choices. Yeah.
And in the exam, when do you bring the surgical option, a TURP option in Parkinson's patient?
We can bring when the patient is young, say 70-year-old or even less than that. There is a role for surgery, and you should do a urodynamics in a Parkinson's patients to make sure that the bladder is healthy, because there is a good possibility his bladder storage symptoms are a part of Parkinson's disease itself. So just by treating the bladder, you may not achieve anything. So you have to do communication letter to his geriatric consultant to see what is the stage of his Parkinson's disease, whether he is responding well, does he needs any alteration in the Parkinson's medications, etc. So better not to go towards Botox or surgical options and try to treat conservatively. For every scenario, not only in BPE table, any table, penile cancer, technology, there will be a theme for the scenario. So theme for that scenario is whether you are able to recognize the high incidence of storage symptoms in an elderly man with Parkinson's disease, whether you are correlating the impact of Parkinson's disease in the bladder, whether you are giving importance coordinating with the geriatrician and making sure you are giving a wholesome care rather than just tunnel viewing only the storage symptoms and treating that. That is the main theme of that scenario. For example, if you take the last scenario, the theme is channel TURP. I will be very happy if you bring the word channel TURP quite in early. Why channeling? Why we are not going for the normal TURP? What is the extra disadvantage of it? And why we are not discussing any newer technologies for a patient with prostate cancer? So there is a theme in everything. Okay. The theme in the patient with a large bladder stone and a large prostate is the open method or robotic method. Those two are the main things. The holmium itself will come only as a second option. So if I am presenting the scenario, I will say for this patient, there are few options available. The first option is open stone removal and simple prostatectomy. Of course, this can be done by the robotic method also, or even laparoscopic method also. The second option is holmium. So I will take it like that. I will place the open in front of holmium. But now there is a lot of evidences coming showing excellent holmium technology, and the surgeons have reached the, what can I say, the learning curve where they can do things in one sitting. So you need to play like that. So that is what the examiner should not hear the other things like TURP or resume or Eurolift. So there is a message or the theme for every scenario. If you get the theme correctly, you can play around it.
Yeah, brilliant. Thanks.
Okay, good. If there is no other questions, we'll conclude the session. We will discuss penile cancer tomorrow. Is that okay?
Yeah, thank you.
Good. Wishing you all a very good rest of the day. Bye.
Thank you. Bye.